Hey there, this is Ari. Welcome back to the Energy Blueprint podcast. Before we get into today's show, I have an incredibly important announcement. This is something that I really haven't been more excited to announce than all the way back in 2014 when I first started the Energy Blueprint. After well over a year of development and testing, we are finally ready to officially launch our breakthrough mitochondrial supplement to the world. This is a genuine game changer in the area of human energy enhancement, and it's called Energenesis. This is actually the first no stimulant, no caffeine, and no sugar energy formula that actually builds up your own body's capacity to produce energy. Instead of working like caffeine and stimulants by giving you a temporary boost of energy for a few hours, but ultimately making your energy levels worse over time, Energenesis actually builds up your own body's ability, your cellular capacity to produce energy. Energenesis got over 20 amazing, powerful ingredients at real effective doses. This is a premium formula that uses actual real effective doses. So this is literally like 23 supplements all in one. And with that in mind, just to mention a few testimonials that people have wrote in after using Energenesis. So this one's from Barbara. She said, I'm a 72-year-old female and I love Energenesis. I have more sustained energy through the day and I'm actually getting my life back. I'm doing things that I haven't been able to do for 10 years. Anya, she said, I really love that it gives me just the right kind of steady and balanced energy. Unlike stimulants, which I can't tolerate, Energenesis gives me a perfect, smooth kind of energy that lasts throughout the whole day. Michelle Catlin, this is one of my favorite ones. She said, Ari, are you getting tired of all the praise and requests for Energenesis yet? I'm on my third bottle and I have to tell you, I haven't felt this good in years. So if you've been struggling with your energy levels and you're looking to get this area of your life handled, and not just to get a temporary boost of energy for a few hours, but to actually transform your energy levels by building real energy at the cellular level, then go get yourself some Energenesis. You can get it at theenergyblueprint.com/Energenesis. So go to that page, check out all the ingredients and all the science behind it, how it works. It's all there. There's about 200 scientific references behind all of the different ingredients in Energenesis. They're all listed on that page along with a lot of the science behind the ingredients. There's also a video explaining it all. Check it all out. Check out the science, then grab yourself some Energenesis and let's get started. I know that you are going to be blown away by the result. The URL is theenergyblueprint.com/Energenesis. And now let's get into the episode. Hey everyone, welcome back to the Energy Blueprint podcast. I'm your host, Ari Whitten, and today I have with me my friend, Dr. Jessica Drummond, who is the CEO of the Integrative Women's Health Institute and author of Outsmart Endometriosis. She holds licenses in physical therapy and clinical nutrition and is a board-certified health coach. She has 20 years of experience working with women with chronic pelvic pain, facilitates educational programs for women's health professionals in more than 60 countries globally, and leads virtual wellness programs for people with endometriosis. Dr. Drummond lives and works with her husband and daughters between Houston, Texas, and Fairfield, Connecticut. So welcome to the show. This has been a long time in the making and a lot of canceled appointments on both your end and my end, but I'm glad we're finally able to connect and make this happen.
Yes, thanks so much for having me.
Yeah, my pleasure. So you have a new book, Outsmart Endometriosis. I'm curious, can you just, for people who maybe don't know, talk about what endometriosis is, first of all?
Absolutely. So endometriosis is a disease process that probably has three underlying factors. There's a lot of debate still in the literature about exactly what endometriosis is, but it does have a genetic component. We see if there were studies done on like female fetuses have this roughly the same percentage, about 9% in female fetuses, 10% in adult women or people with uteruses that are presenting with endometrial cells, endometriosis lesion cells. And then there's also an inflammatory factor and there's an autoimmune factor. So from my perspective, I think of it as like cancer or Alzheimer's, where you have the physical lesions, the plaques, the tangles, the cancer cells, and then they can be worsened or progressed, proliferated by inflammation, and there's an underlying autoimmune component. Also, there's a lot of comorbidity with other autoimmune diseases.
Very interesting. So it's cells that are where and are doing what?
So there are cells that are very similar to, but not exactly the same as the lining of the uterus, which is called the endometrium. So these are cells that are very similar that are by definition growing outside of the uterus. So they're generally growing like on the outside of the ovaries, the outside of the uterus, on the bowel, on the small intestine, anywhere in the abdominal pelvic cavity. You also see more extrapelvic endometriosis in some cases, which is more rare, but still available. You'll see it in places like C-section scars on the lung. It's even been found in the knee and inside the nose. So it's kind of like little cancerous lesions, but it's not a cancer. It's actually benign from that definition.
Okay. So when you say it's cancerous lesions, what exactly do you mean by that if it's not a cancer?
So it's not cancer. It doesn't act like cancer. It's not fatal, but there are like cellular lesions of several different types of these cells made that are like the lining inside the uterus. So ideally, the treatment includes having those lesions cut out, but that's not the full picture. Just like in cancer, we want to lower inflammation, optimize immune health, and that sort of thing. So it's different. It's not like it's not deadly in the sense that cancer is, but it's very quality of life altering, and it does increase the risk for certain cancers such as ovarian cancer, but even melanoma. People with endometriosis have increased risk of melanoma. So there is some overlap, but it's not exactly the same.
Interesting. Okay. So it impacts quality of life. It's not really that deadly, but it impacts quality of life. So I guess there's two layers to this. One is subjectively, how does someone get impacted in terms of their quality of life? And then, well, I guess answer that part first, and then I want to go into the mechanisms of what it's doing.
Okay, yeah. So usually it presents in a timeline, which is hard to see usually until you're looking backwards, but pre-puberty. So it's definitely sort of heightened or expressed at puberty, but pre-puberty, you often find like around between 8 and 12 years old, a girl presenting with things like stomach aches, digestive issues, and then bad periods. But when they're teenagers and preteens, the period pain is not generally cyclical. It can be kind of any time. And you'll have this family history of moms, grandmas, aunts, sisters having, bad periods, terrible periods run in our family. Infertility is very common. A lot of pelvic pain, sexual pain, digestive issues. Also an overlay of fatigue and anxiety, which I find is generally related to the digestive issues where it's a challenge with absorption. Mm-hmm. Because don't forget, a lot of times these lesions are growing on the small intestine and bowel. So there's endobelly, which often really is SIBO, because you've got adhesions and lesions growing on the small intestine, which create these perfect little pockets for bacteria and other microbes to thrive. Motility can slow down. And so you have like bloating, digestive issues, constipation, and then period pain that doesn't start off kind of perfectly cyclical, but eventually can be cyclical or can be all the time. It's actually the number one reason that girls miss middle or high school, because they have this kind of intense pain with or even without their periods. Meaning
like days of school missed or like entirely pulling out of school?
No, days of school missed. So okay. Staying home sick or, in pain.
Interesting. So it's fascinating to me that the kind of the range of how this can be expressed in terms of symptoms, from pelvic pain to infertility to gut symptoms to bad, period related symptoms. I think there was a few others that you mentioned in there. like how does this actually work in terms of the mechanisms that are causing these effects? Is it sort of like almost like senescent cells that are producing inflammatory cytokines in the area, or what are they actually, what are these cells doing to create these symptoms?
Yeah, so there is the kind of structural physical problems where you've got cells kind of growing on lesions growing on the bowel, so it's kind of structurally impairing motility, or getting in the way of the functioning of the fallopian tube, things like that. So there's like the structural piece of it.
How
But
big
yes,
can they be in
they
that
can be
regard?
quite big. The endometriomas can be very big, like grapefruit size.
Oh, okay, so they can create like sort of what maybe manifests almost in terms of the phenotype, in terms of the looks, like a cancerous tumor.
Correct. But they could also be microscopic. They can
Okay.
also be little black or red kind of tinier things that are visible, but they're not giant. So there's
Mhm.
several different expressions. So there is a structural component, but yes, we also find increased inflammatory cytokines and increased auto antibodies sometimes that are similar to things like lupus antibodies or rheumatoid arthritis antibodies. So, and in fact, when the lesions are removed by having skilled surgery, the antibodies decrease, at least for a transient period of time of at least 6 to 12 months.
Very interesting. So you mentioned fatigue as one of the symptoms of how this can manifest, which is obviously of great interest to people listening to this podcast. What would be the mechanism of how it would cause fatigue? Is it the inflammatory cytokine component?
That's part of it. So mitochondrial kind of overwhelm is one piece. I think another piece is lack of absorption of amino acids. So you end up kind of with, or even nutrients in general. So kind of nutrient deficiencies, both macro and micronutrient deficiencies, because you have so much digestive issues and a lot of pain with eating. I think it's also really the clinical journey of trying to be treated, because it takes an average of 6 to 12 years for this to be diagnosed. So
Oh, wow.
you have a lot of people telling you, oh, it's all in your head, this, just try birth control. Like in general, it's not well managed by Western medicine. So the path of getting a true diagnosis. And the other big challenge is the only way to get a true diagnosis is through skilled laparoscopic surgery.
Oh, wow.
So you can't just do like imaging or a blood test. You can sometimes see some of these things on imaging, but if you don't, it doesn't rule it out.
So within the path for diagnosis being so invasive, they're probably not rushing. I mean, both patients and practitioners are not rushing to check, I
Right.
would imagine. So that's probably a big barrier. And so you have this problem, as you said, of so many people who maybe are suffering from these kinds of symptoms, pelvic pain or infertility or fatigue, um, period related symptoms, um, that are dealing with this for years and years and years before they ever get to this stage of, okay, we've exhausted all other options. Let's perform this surgery to check for endometriosis. Is that accurate?
Yeah. And the other thing that can happen is because there is a genetic component, it can be sort of normalized within even the family
Mm,
for a period of time. And there's such a wide range of presentation. For some people, it's super debilitating pain, like a lot of the time.
mm.
For other people, it's actually silent and they don't even know they have it unless they're struggling with infertility or something like that. So I think that's part of the problem too. You have a wide variety of presentations, and if everyone in the family has kind of period pain, well, that's sort of normal, right?
Mhm.
So there's not even a strong explanation. And then the training, I was talking to Betsy Greenleaf, who was the first female urogynecologist board certified in the US, and she said she didn't even really learn any of this in school.
Wow.
So it's not well trained. Like most gynecologists and even urogynecologists haven't been well trained in kind of the deep dive management of
You're
this.
saying even for gynecologists, they're not well trained in this.
Yes.
Oh,
Mhm.
wow. Okay. So if Having said that, there are these symptoms you mentioned. There are this wide variety of how this may present or manifest. It might be normalized in certain families. You have this very invasive way of going about needing how you would diagnose this. If there are people listening to this, if there are women listening to this who are saying, yeah, some of these symptoms seem to resonate with me, maybe I should get checked for endometriosis. Maybe that's a cause of my fatigue and pelvic pain and some of these other things. What would you say are how would somebody present to you clinically in terms of their symptoms and what they're describing? Are there issues that would make you say, I would bet, a lot of money that this is 99% going to be endometriosis. You should get checked for endometriosis. What would that look like?
Yeah, I think the history really tells us that kind of timeline of digestive issues, family histories of infertility, family history of pelvic or period pain. A lot of people kind of going on birth control just to quiet their period symptoms, maybe even this person herself. Even the other thing that you kind of hear, and we were talking about this at one of the endo conferences recently, kind of going in the bathroom in middle school or high school and like sitting on the floor in a cold sweat from the pain, and just sort of like resting your chin on the toilet because it's cooler. There are certain like things that we hear over and over in the history that really point to this. And then, because there's that family history component, and then a lot of times the only treatment that's been given would be something like pain management or hormonal birth control, which sometimes helps, sometimes doesn't. And so having kind of that path is where really I can say, this very commonly sounds like endometriosis. Two other things that are also very common are bladder pain symptoms, because the endometriomas or the various lesions can grow on the bladder. So chronic UTIs, chronic bladder issues, bladder pain syndrome without a true cause, maybe not urinary tract issues that weren't ever shown to be bacterial. And then pain with defecation, again, because of how often the bowel is involved. So it's that overlay of more than just painful periods, but like intensely painful periods. And a lot of times when you talk about this, so it's 10% of women or people with uteruses. So if you're in a group of like 20, 17-year-old girls, they sort of know who the two are that have it.
Interesting. This is a topic that I've never really looked into in depth, so it's very interesting for me to hear this. My wife has definitely told me on numerous occasions that when she was in high school, that she had incredibly painful period symptoms, and that her sister did, her mom did, her grandma did. Migraines also, I'm curious if that's related to this constellation of symptoms, if migraines are also associated with endometriosis. But incredibly painful periods that were debilitating. She told me she fainted one time in school from the pain. And my wife is actually very physically tough, not anywhere near the hypochondriac end of the spectrum. So if she says she was in a lot of pain, I definitely believe her. They were, both her and her sister put on birth control to mitigate these symptoms back in high school. So I'm just curious, are migraines associated with it? What I just described there does that fit with the narrative, or do you think could be something else?
Yeah, that definitely does fit with the narrative. I mean, we'd have to dig a little bit more. Were there other, bowel or bladder issues? Were there any infertility challenges in her family or for herself? Did the birth control help? Because we used to think up until early 2018, the prevailing thought was that the lesions were mostly sort of fed by estrogen in the same way that breast cancer lesions are fed by estrogen. Now they did some histological studies in Belgium in 2018, and they've been also similar results have come out of other labs, that when you look at the lesions, some of them have upregulated estrogen receptors, some have more progesterone receptors, some have both, some have neither. And so, and all of these different kinds of lesions can present in the same person. So for those that do have these sort of estrogen driven lesions, there are a lot of estrogen suppressing medications, including, of course, hormonal birth control, that do help. But there's a lot of people who don't respond to that. So we're sort of like, well, why not? If we're suppressing the estrogen, how come they're still having so many symptoms? And now we know it's not that simple. And of course, there's the inflammatory component. So if, and the work that I do is kind of everything, obviously, except the surgery. So the more we can optimize immune health with lowered inflammation, improvements in, the barriers between the digestive system and the immune system. So lowering kind of the autoimmune presentation or challenges there. And then just normalizing the hormones, but not really trying, making sure estrogen is being metabolized well, make sure there's not so much xenoestrogens from plastics. And like, as an example, I had a client in the Middle East, super hot. She was having all these estrogenic symptoms that she realized she was wearing plastic flip-flops all the time. And it was kind of like absorbing through her skin.
Interesting.
So lowering kind of the toxic load, supporting liver and gut metabolism of estrogen, but not fully suppressing everything, is really a better approach. So sometimes that's really helpful to be on birth control, at least for the short term while they're sort of having a diagnosis. The problem is that a lot of times then, so say your wife and her sister were put on birth control at 15, 17, then they just leave. If it quiets the symptoms, then the only, kind of perspective is like, hey, let's just leave the person on it until she wants to get pregnant. But you've kind of left this disease process manifesting for all of those, for a decade or more before someone is trying to actively get pregnant, and you're not trying to optimize the health of the system. Does that make sense?
Yeah, absolutely. So I'm curious in terms of causation, is this like obesity, like type 2 diabetes, like cardiovascular disease, neurological diseases, cancer? Is this a disease of civilization? Is this something that has skyrocketed in the last 70 years with the rise of the standard American diet, the modern Western lifestyle? Or is this something that just a portion, whatever 10% of women have had going back, millennia?
As far as I can tell, it's 10% of women. That number has remained fairly constant. What I would say potentially, although it's really hard to say because the treatment of this hasn't been very good, like up until even, there are some really good excision surgeons in the US and even globally now who kind of take a very holistic approach. They see the excision surgery as being, the valuable part of the puzzle, but not the whole thing. Even that is very new. So I started treating this 20 plus years in my practice. At that time, we used to say a lot of ablation surgery, which is basically go in and just try to burn off these bad cells, right? And I would very commonly see someone having, 12, 15 ablation surgeries. They just keep going in and like trying to burn it off, not really ever dealing with kind of the whole organism. Whereas excision, the goal is to do 1, maybe 2 surgeries in a lifetime, and ideally support all of these other factors, immune health, hormonal health, and so forth. So because endometriosis until very recently, like we're talking the last 5-10 years, hasn't been well managed at all, it's very hard to say if it's worsening. I see the picture of how people are recovering if they have a good treatment is a lot better than I used to see 20 years ago. We used to kind of go down these spiraling paths of pain management was sort of like the best you could do. We'd do manual physical therapy. There, even people would have like, stimulators inserted into their spine to try to manage the pain, a lot of opioid use. So in that sense, it's sort of improving. I can't say that like the numbers are increasing because of an inflammatory lifestyle, but I definitely think that managing inflammation could really make the the therapeutic outcome a heck of a lot better.
If it seems to me that if that is the case, I mean, let's imagine a scenario where like there just isn't good data for people with type 2 diabetes, and we have no history of testing up until the last, let's say, 10 or 15 years. And we don't really know how common it was going back 70 years ago and so on. We don't know what's causing it necessarily. But we figured out that if you change people's diet from a standard American diet to a whole foods diet, rich in plant foods, and you get them to lose 10 or 15% of their body weight in excess adipose tissue, that you reverse the insulin resistance and can, in many cases, or in most cases, cure the type 2 diabetes. It seems just logical to conclude that if those nutritional lifestyle factors are good therapy, that poor nutrition and lifestyle are probably part of the cause of the problem in the first place.
Sure. I mean, that very well could be. I think the challenge is, as you just said, we don't really know. We don't have that same kind of data before, kind of 70, 50 years back. Before really it was just even 20 years ago when I started treating this, there was burn it off and take estrogen blocking drugs. So basically they would put people into a chemical menopause, which had horrible side effects and still does. That's still a common treatment. When you're 17, to be put in chemical menopause, it's like terrible for your bones, terrible for your brain, terrible for your heart. Hysterectomy used to be like a treatment, but of course we know that doesn't do anything because the lesions are by definition outside of the uterus. Now, in some cases,
when in doubt, just take out the uterus and burn it off. That's my approach to pretty much all medical problems. Just burn it off.
Well, and honestly, that's really the true gynecologic, wizardry that we had. Yeah. And so,
there was a client who came to me recently and he's like, I have erectile dysfunction. I'm like, burn it off. Get rid of it.
Right. And that's really how women's health has been literally up to about 20 years ago. Wow. And even overlapping, the last little bit. I mean, a lot, even now. So there's this sort of sister condition called adenomyosis, which is these lesions that are inside the uterine musculature. So in that case, doing a hysterectomy is sort of the only treatment. But again, you can't know until you've done the hysterectomy. Now, obviously, people who are really skilled at this, kind of the same way you just asked me, can tell from, they've tried treating everything. They've tried treating endo. They're doing all the other stuff, still having a lot of pain. The next thing to do is take out the uterus and hope that it was adenomyosis. So
interesting.
Yeah.
Wow. So, but in the last 5-10 years, it sounds like the state of the science and the state of standard of care treatment has advanced a lot. Can you tell me what sort of a conventional medical treatment would look like for somebody as of 2020, would look like for somebody who is diagnosed with endometriosis? And then I want to talk about what your vision of the ideal treatment should look like.
Yeah. So still, most general gynecologists are going to prescribe birth control or pain management or something like that. Sometimes they'll do like a look around laparoscopic surgery where they'll kind of look around and see if they find anything. But the people who are very well trained in what's called minimally invasive excision surgery, so they go in and they like do this all day, every day. They're not also delivering babies. Like they're going in and taking out endometriosis or similar kinds of lesions. That is a very different kind of surgery that takes a lot longer. Obviously, it's more complex. Often they have a general surgeon there or a GI surgeon because bowel is so often involved, or, a urologist or a urologic surgeon, so there's a whole team that's really prepared. And the challenge is that for the physicians, the reimbursement's the same. If you go in and like look around, or you have like a 10-person team, full day surgery, your reimbursement's the same.
Mm.
So most of those surgeons that are really good at this practice in a cash-based kind of system. And they're still having a lot of trouble getting true buy-in from ACOG, the general, organization that oversees the gynecologist. So depending on if you see one of those specialists who, there are, 100 in the US or something like that or less, or you see your regular family gynecologist, your conventional treatment will be very different. So one would be a very skilled kind of surgery situation. And in some cases, some pre-op and post-op management, not always, that sort of varies, depending on their perspective and everything. And then other times, it's the same thing as it was 20 years ago. Look around, maybe burn it off, maybe excise it, birth control, pain management, estrogen suppression, things like that.
Okay. Got it. And what does your approach look like?
So my approach is ideally, now not in every case do my patients have surgery. There's a lot of reasons why you would choose not to have surgery, but assuming they're going to have surgery, and even if they aren't, we want to spend about 3 months preoperatively or just in general, really optimizing the digestive, immune, and nervous system from a nutrition and lifestyle standpoint. So sleep, generally it's kind of a backbone of an autoimmune paleo kind of food plan that's very plant heavy. There is a lot of bladder issues. So sometimes there are oxalate and histamine sensitivities that we have to manage. Digestive function is huge, increased intestinal permeability, low stomach acid is really common, dysbiosis, SIBO. So kind of managing all of the digestive function issues, lowering inflammation, and then that expands to lifestyle. Do they have mindfulness practices? What's their exercise look like? Sleep, stress management, all of that. Then, be much better prepared for surgery so that neurologically, of course, surgery is kind of an inflammatory insult just by definition, but going in with a quieter nervous system, not so much, sympathetic upregulation, really quieting all that, then following up outpatient or the other side of surgery about 6 weeks for anywhere from 6 to 24 months, depending on the recovery and how extensive the disease was and how complicated the surgery and all of that. And then other people can have complete symptom relief without surgery by doing the kind of holistic approach of nutrition and digestive support, immune support, liver support, nervous system support, and pelvic physical therapy, which addresses the kind of myofascial pain involved in the pelvic region, low back, hips, that sort of stuff. So that can happen. We can actually have complete symptom relief I don't know what the percentage of cases is, but certainly in some cases. The reason that I still encourage clients to at least consult with an excision surgeon is that we can have symptom relief, but we will not be able to necessarily change fertility. So we want to at least give them the opportunity to consider, what their fertility plans are, because having the surgery could really preserve fertility. Interesting.
Of all those things you just mentioned, what do you think are the biggest needle movers?
I think gut microbiome, digestive function in general. Stomach acid is a huge issue because there's so much dysbiosis. And of course, to me, it's like, how would you get all this bad bacteria in your small intestine? There's only 2 ways, right? Eating it, or it comes in back from the ileocecal valve. Now, a lot of times with maybe even other surgeries before someone's come to see me, the bowel has been changed such that the ileocecal valve is not functioning anymore. So we're kind of always battling some level of SIBO, some slow motility. So I would say an anti-inflammatory diet in general in the context of optimizing digestive function.
Got it. Very, very, very interesting. Are there any other aspects of this that you feel are worth delving into in more detail? I feel like I've learned a lot about endometriosis. This is, as I said, a topic I've done very little research on and have very little expertise in, or no expertise in, I should say. And this has been enlightening for me. And I feel like this is just a really wonderful tour of this whole landscape of what it is and how it works and the mechanisms behind it and what conventional treatment can do, what someone like you can do. Are there any other aspects here that you feel are worth digging into in more detail?
I think the one other thing is that we know a lot more about pain neuroscience than when I first started in practice 20 plus years ago. And I think that information is really reassuring too. So from a nutrition standpoint, when you're optimizing digestive function, you're much better at absorbing kind of the building blocks we need to optimize brain function, right? So quieting any mitochondrial, oxidative stress. So lots of antioxidants, amino acids. So getting protein absorption is key for balancing neurotransmitters, making sure someone's not anemic because there's a lot of heavy bleeding that can go along with this, the menstrual bleeding. So when the kind of biochemically the brain health is optimized, it's a lot easier to use our pain neuroscience strategies to reduce pain from a musculoskeletal standpoint and from a behavioral standpoint, so that we don't have to use such intense like neuromodulators and pain medications that often have a lot of side effects and may or may not be very effective.
Very, very interesting. I do have one more question for you. Are there any specific supplements or herbs that have any kind of known efficacy for endometriosis?
Yeah, there are several. Probably the ones I would highlight the most are certain antioxidants. So turmeric has about 12 different mechanisms that we can use, curcumin for lesion, improvement, lowering inflammatory cytokines, things like that, even gut microbiome improvement. French pine bark or pycnogenol has been shown even in human studies to decrease the size of endometriosis lesions. So those are two really good ones. Another one for period and pelvic pain is fish oil. So those are three that most of my patients, I'm doing a kind of constellation of antioxidants because I'm lucky because I was originally trained as a physical therapist, not as a physician, and then my doctorate's in clinical nutrition. So I don't think in that model of what supplement do we need for this, And so when you kind of have this foundation of antioxidant rich and mineral rich and amino acid rich food plan, then those other antioxidants at like therapeutic levels can be really effective.
Very, very fascinating stuff. Dr. Drummond, thank you so much for coming on the show. I really appreciate you sharing your wisdom with my audience on this topic, which is something that we've never addressed on the podcast before. I think it's an incredibly important topic. I'm sure there's lots of women listening to this who are thinking, maybe this is the missing key for me. If somebody wants to follow your work, if somebody wants to get in touch with you and work with you, I'm assuming you do some telemedicine, or are you just in the physical clinic for people in your local area in Connecticut, or?
Oh no, we have a telehealth practice globally in nutrition, and we also have some coaching programs for people to do group coaching. So we work with patients all over the world.
Excellent. So if somebody is listening in, they want to work with you, where can they reach out to you?
So our main website is integrativewomenshealthinstitute.com. And if anyone wants a free kind of downloadable copy of the book, I'm happy to give it to them at outsmartendo.com.
Oh, that's nice.
And then we're on Instagram and Facebook and all of that. Instagram is probably the fastest way to find me at Integrative Women's Health.
Beautiful. And so would somebody just out of curiosity, would somebody be able to work with you specifically, or would they be working with other people in your clinic?
So I do kind of our deep dive strategy session, and then, looking at all the details, if they've had any labs or, things that are more complex, I do those personally. And then we also have a team of coaches who most of them are also pelvic physical therapists. And we do a lot of telehealth coaching with the team. So we do both of those things, but I'm pretty hands-on in my clinic.
Excellent. Well, this has been fascinating stuff. Thank you again for sharing your knowledge. I really appreciate you coming on the show, and I'm glad we were finally able to make this happen. for everybody listening, hope you enjoyed this. And I hope that this maybe is the missing key for many people listening to this, many women specifically. I don't want to speak in the politically correct terms where we're being inclusive of everybody if this is a women specific issue. It is women specific, right? It's entirely women, right?
Well, it's generally women specific, although there are transgender men who also deal with this. So anyone who has a uterus from birth.
Okay. Yeah. Got it. Fascinating stuff. Thank you so much again, Dr. Drummond. Really appreciate it.
Thank you.
Hey there, this is Ari again. One more quick thing before you go. Just make sure to subscribe to our YouTube channel, The Energy Blueprint, and also make sure to subscribe to this podcast on your favorite podcast platform, whether that's iTunes or Stitcher or anything else. I hope you guys enjoyed this interview, and I will see you again next week.